It seems some people can make a mighty good living these days just trying to figure out why some patients end up in the ER or in the hospital and why others being treated the same way don't. So that's what we're talking about, predictors of increase in emergency room visits and hospitalizations in patients with chronic lymphocytic leukemia treated with chemotherapy. And we're at the ASH meeting on hematologic malignancies in Chicago. And I am here with William, although better probably known as Brad Schenkel, who is director of the Janssen Scientific Affairs and Health Economics and Outcomes Research Team. Now, for people with chronic leukemia or any disease where they're getting treated with chemotherapy, it can really impact them in a number of different ways. Indeed. Why did you do this study, first off?
Terrific question. Well, first of all, acute care interventions such as emergency room visits and hospitalizations have a negative impact on patients' quality of life, a significant negative impact. Also, they're a major cost driver in the oncology care, all the way from the beginning through the end of oncology care. So for those two reasons, we really want to do this research. There's not a lot of research in this area. In fact, when you look at the literature, very, very little research on this key topic, especially in the new healthcare reform world that we live in.
Right.
So we felt this was an important research project.
So what did you do specifically?
Well, we did a univariate regression to look at the variables that are associated with increased or decreased healthcare resource utilization, namely hospitalizations and emergency room visits. We analyzed claims data, 4 years of claims data, and looked at 22 variables, 18 of which ended up being significantly predicting hospitalizations and 16 significantly predicting emergency room visits. And so we did this analysis, and many of the variables that predict hospitalization are also similar to those that predict emergency room visits, things such as patient's age, Charlson comorbidity index, number of prior therapies, and certainly other variables which I can mention, but it's very telling.
So how many patients did you look at?
In this claims database, we looked at 2,013 patients who fulfilled the inclusion-exclusion criteria. We used ICD-9 codes to identify patients with CLL, the appropriate ICD-9 codes. We excluded patients who were less than 18 years of age. We wanted to look at adult population. We excluded patients with pregnancy. And we ended up with 2,013 patients. By the way, we also excluded patients with secondary malignancies. Okay. Because that would certainly affect the hospitalizations and ER visits. So we really want to get
this was over a period of time, too.
It was.
Several years.
It was indeed. It was a 4-year period from 2009 to 2013. So people with claims that show treatment with anti-cancer systemic therapy between August 2009 to August 2013 were included. And so we had 2,013 patients. Of those patients, approximately 40% had ER visits, and approximately 40% also had hospitalizations. The median age was 72. There are certainly many attributes that we studied about the patient population, but two attributes especially that show the representativeness, so to speak, of the population were that 60%, a little more than 60% were male, and CLL is indeed affects males more often than females, and also so there were other attributes of the data with the median age of 72 that was very representative of the patients who have CLL.
So what can we tell about preventing this now that we have some of the ideas of the predictors? How do we intervene in that?
Terrific question. So the idea here is that if we know more about this data, what's predicting ER visits and hospitalizations, maybe we can improve the management, right? So that's really the thought here. With these variables in mind, perhaps we can better manage CLL. We can improve satisfaction and quality of life for patients potentially, right? As a nice potential future. So that's really the idea. So when we look at these variables, again, the adverse events, the Charlson comorbidity index, et cetera, when doctors are thinking about what therapies they're going to use, they can keep these in mind to better manage the patient's health throughout the disease course, potentially lowering the number of days in hospital or preventing that hospitalization. For instance, some of the key variables were presence of anemia, presence of thrombocytopenia, presence of certain cytopenias. So, whether it's management of that anemia earlier or quicker management of that anemia can potentially lower these healthcare resource utilization elements.
Now, you used a phrase, you talk about comorbidity-adjusted treatment choice in CLL. What are you talking about with that?
So comorbidity-adjusted treatment choice. So the comorbidities that are mostly associated with CLL, including those that we looked at, included infection, anemia, thrombocytopenia, and several others, but those were certainly at the top of the list. And what we meant by that is that treatment can be decided upon based on some of these adverse events. If we're able to select or bring therapies earlier in the treatment pathway that are less associated or not associated with these cytopenias and the infection, that will be not only good for the physician in the hospital and such, but also certainly for the patient.
So does that get to, if you have chronic kidney disease, for example, there may be adjustments in the dosing just simply because you know that there is an issue with the kidneys?
Well, that's interesting. In terms of the dose of treatment you're referring to?
Yeah.
Well, I mean, that's something that the physician would certainly have to decide upon. I mean, if he's going to choose a therapy, he wants to choose the right therapy. I think it has a little bit more to do with the choice of which therapy and at what point in the disease course.
Okay, that makes sense.
Right. So yeah.
So anything after this? Now that we've learned all of this, what are we going to do with that knowledge?
Yeah. So with this knowledge, so we have these predictors. We see which are significant. By the way, all the variables I noted before. Of the 22 variables, 18 being significant for hospitalizations, 16 being significant for ER visits, we found that none are indicative of decreased healthcare resource utilization, which is interesting, I think, because we also looked at that as well. So where do we go from here? I think there are a number of areas we can go to. First of all, this study was based on claims data. Now, that has a number of limitations. First of all, it does not have disease severity. It does not have certain clinical information that a chart review or an electronic medical record review might have. So in the future, what we might be able to do, us or other investigators, can bring in other types of data and analyze whether response rates, partial versus minimal response, elements such as that, can also serve to predict hospital resource or healthcare resource utilization. And I think that'll be very telling.
Well, there are a variety of studies here at this meeting that I found really interesting, so I was very happy that you had some time for us.
Thank you.
We have a variety of videos and also, of course, news in ASH Clinical News that we would like you to check out. For ASH Clinical News, I'm Rick McGuire.